We can see your gratitude to the American taxpayers that over the past 2 decades they have been supporting NTD programs through US aid. It's really the generosity of the American people and the long-lasting commitment that is so much appreciated that tremendous impact has been achieved thanks to their partnership. They have been supporting the countries, they have been supporting WHO on reducing the burden of NTDs. As the US take a pause to reconsider their foreign aid strategy, we, from WHO and from the African people, we send our most sincere gratitude and recognition to the American people. And we look forward to identify new ways to continue working together to combat and eliminate neglected tropical diseases that affect the poorest people in the world. I personally think that it's this tremendous generosity that characterizes the American people that have made America great in the eyes of the world. 2025 represents a transition year for the US cooperation, and therefore it has associated risks, such as program disruptions, medicine expirations, increase in disease transmission, morbidity, and mortality. Therefore, there is an urgent need to identify solutions to mitigate those risks and design a strong nationally owned action plan. 2025 is also the year of the NTD Roadmap midterm review and the development of acceleration plans towards 2030. As you know, the NTD Roadmap calls towards increased country ownership and leadership. It also reiterates the importance of mainstreaming NTD delivery programs into the health system and into existing national platforms. That is why we are here today, to gather together to identify domestic opportunities and domestic solutions for action, to define national action plans to ensure the NTD programs do not get disrupted in 2025 and that national solutions are identified. Countries are now going to be invited to present their current mitigation strategies to identify ways to deliver NTD medicines in 2025. You know, we often think that if we were only powerful enough, like a president, if we were rich enough, like Bill Gates, then we could do something. But we are just so little, we can do nothing. But honestly, often is the opposite. Governments can do nothing without us. They can do nothing without the people in the ground. And it is typically the people in the ground that knows actually the best solutions, the more real solutions. We all see that when there is a person that passed away in a community in Africa, how the community mobilize themselves to organize a funeral, or when there is a wedding, how everybody dress up and they come from far, they mobilize food and drinks are available. Who can tell us that this type of community-owned solutions cannot be made available to distribute NTD medicines? Maybe there is no per diems or there is no lunch allowances, but the community can do better meals and better recognition. But anyway, I'm talking too much. Let's listen to the countries first. I'm going to ask the program managers that when they present, they focus on the community and nationally owned solutions and avoid to say that they are going to mobilize resources from another different partner. Let's talk about specific actions, such as integration with other health programs, vitamin distribution integration, BedNet distribution integration, mainstreaming into health systems, delivery and supervision through health facilities, integration with schools, community mobilization, organizing meetings across different sectors, distributing through supply chain management in the regular systems. So, having said that, we are going to start with our first country. I'm going to ask my colleague Nadia to upload the presentation. These are all the countries, if we can go in presentation mode. We just put them in alphabetical order. And I'm going to invite the first one, Mr. Kadu Meribo from Ethiopia.
Please upload my presentation.
Next slide, please.
Okay. This is the area that we have, the program area we have identified that impacted by USAID fund freezing. 3 programs, onchocerciasis, lymphatic filariasis, and trachoma. Onchocerciasis with a total population 7.7 million, and lymphatic filariasis with total population 2.4, and the trachoma 9.8. Second, please. Next slide. This is the drug that we identified nearby expiry date. We have 95,000 ivermectin tablets that expired on 31 October 2025, and the rest medicine in 2026. Next. This is implication of funding freeze, that drug will stage for near expiry date, lack of trust by community because of stopping day without notification, extend preset of elimination goal, reverse program if a immediate around this interacted more than one, especially in onchocerciasis. Next. This is national solutions that we have identified. I emphasize on the domestic local solution. As a local solution, we start conversation with the regional health bureau and stakeholders, especially in integration, that to integrate impacted program to other NTD program like schistosomiasis, soil transmitted helminthisis, and even other program within the health system like immunization, family planning, and nutrition. So integration, we have started integration within NTD in 2018. We have experience integration. So by integrating, we maybe minimize these challenges. For example, in western part of Ethiopia, many districts is endemic for neglect tropical disease, lymphatic fibrosis, onchocerciasis, soil transmitting helminthisis. We can administer ivermectin and albendazole as a single dose for 3 diseases, and also we can coordinate other program like trachoma and trachoma schistosomiasis. So by integrating within NTDs and general health service, we can minimize, we can mitigate this problem using the existing platform. So currently in Benishangul Gumuz, Asosa and Kamashi, one of the areas that impacted by USAID funding freeze, they start MDA using this platform, integrating the activity with other program and using some small money that they have received before USAID work stopped. Currently, they are running onchocerciasis mass drug administration. Also, we are discussing with the Oromia Regional Health Bureau for 77 districts that onchocerciasis area impacted by USAID work stop order. So this is one way. And doing this, we plan to increase community involvement, participation, and also conducting advocacy workshop to gain support from regional government. Our country is running federalism, decentralized power. So we plan to negotiate, conduct advocacy workshop for regional health bureau and stakeholders. So we also, according to the government direction, the government can mobilize domestic resource working with existing potential funding and implementing partners. And currently, starting yesterday, we are developing mitigation plan that will be presented for government higher officials and potential partners, and also that we will use to advocate our stakeholders and the regional health bureau or officials, government officials. So we are going to work hard in this area, emphasizing on a domestic solution. This is my presentation.
This is excellent, Kadu. Thank you so much. I really like this solution of talking to the regional governments and try to find also support from there. Can we move to the next slide, please? Thank you so much. Ghana, please, we have Dr. Joseph.
Yeah, good afternoon, everybody. This is Dr. Joseph Kwajo Labiopare, Program Manager, Ghana, presenting at the moment. Next slide, please. Next slide. So it's rather unfortunate that if it continues to be like this, where we are not going to get funding for these activities, then also we must take note that Uncle Sekasis that is due, Uncle Sekasis MDA that is due come next June, involving about 5.8 million eligible participants cannot be done. LFMDA, looking at a population of about 400,000, cannot be performed. We have Stop Onco MDA activities in 4 operational transmission zones. We cannot move forward. We cannot do THAS transmission assessment service. We have one in a district called Elembele. We cannot do that. Then we have also task 2 happening in 3 districts. We cannot go ahead. Then we also have Stop Onco MDA survey. These are new ones that we are bringing on board in 3 operational transmission zones covering 49 health districts. We cannot do that. We had planned for coverage evaluation survey in 3 districts. We cannot also move ahead with this activity. Next slide. All right. Cross-border meetings we plan holding with Ivory Coast and Burkina Faso will be affected. And of course, Ghana Onco Expert Committee meetings we cannot hold. Well, but this one, when it becomes critical, we must find some money within the program to do that. Next slide. Right, so we have a whole lot of praziquantel in the system now near expiry. So if there's this freeze is going to continue, then come October, we cannot use we may not get money to use the praziquantel and that is supposed to be used for the schools and the community. Ivermectin, we have some of them expiring in June. So July. So if we are not able to work with them in June, then those will be affected, as well as albendazole that we are supposed to use for LF treatment, albendazole and ivermectin. Next slide, please. So this is what we are proposing, if it's possible, but it's just in a planning stage. Malaria is doing what the malaria elimination program in Ghana, that's what we call seasonal malaria chemoprophylaxis, okay, where they go to the communities and share the malaria tablets. So if it comes worse, as they are going into the community, we are going to also join them, partner with them to distribute our ivermectin and albendazole against LF and Onco. We are looking at a possibility of using child welfare clinics, outpatient departments, okay? Then looking at also looking for support to implement these activities, that is MDA, maybe getting the community members to support one way or the other. But it's not that easy because you have to plan and test the system and be sure that it works before we can go ahead with such an activity. Next slide, please. Right, so basically this is what we have. It has become a very short timed activity, but we wish that come in a few months ahead, all these activities, all these statements will be resolved so that we can hold the MDAs to ensure elimination of NTDs by 2030 as slated in the roadmap for WHO. Thank you very much. Over.
Thank you so much. That was really excellent. We invite now Mozambique. Dr. Hennis.
Good afternoon, everyone. Do you hear me?
Yes, we can hear you very well.
Yes. This is Hans Muir, National Entity Manager from Mozambique. Sorry, I will present with the Portuguese because I'm not comfortable to talk English. My official language is Portuguese.
Yes, você pode falar em português? Nós hemos traducido. So he's going to present in Portuguese. The slides are in English, and if he adds anything, I will translate it into English. So você pode falar.
Yeah, bom, obrigado. Nós também, como é sabido por todos, fomos afetados por esse congelamento. Então, este slide mostra o número de população que foi afetado por doença, como tinha sido solicitado. Pode passar para o slide seguinte. E nós organizamos a nossa proposta em termos de intervenções por doença e por atividade. Em relação à oncocercose, nós temos 4 distritos que iniciaram as campanhas de tratamento massivo no ano passado e que precisariam de realizar a segunda ronda. Ah, para a mesma doença, também com fundos da UZ, iríamos realizar o OIM em 13 distritos, embora tenhamos ainda 93 distritos que, em função do mapeamento de exclusão que foi feito, mostrou que tem condições para albergar o vetor transmissor da oncocercose. Quanto à filariase linfática, nós teríamos 2 distritos que falharam o último tratamento ou a segunda ronda de tratamento depois de ter falhado o último inquérito, porque o medicamento não era suficiente e chegou mais tarde. Mas também, para além da campanha, temos uma série de inquéritos. Temos o TAS-2, depois temos o REPRETAS. O TAS-2 seria em 42 distritos, enquanto que o REPRETAS seria em 35 distritos. Em relação ao tracoma, temos ainda 8 distritos que deviam fazer MDA e também temos uma série de inquéritos. Temos inquérito de impacto, temos inquérito de vigilância. Então, para inquérito de vigilância, temos 7 distritos, mas para inquérito de impacto, tínhamos apenas um distrito. Pode passar, Maria. Em termos de estratégias para mitigação, bom, está claro que é um desafio, mas esse desafio está relacionado pelo fato de alguns outros programas terem também alguma dependência financeira da UZ, mas tem a sorte de alguns dependerem, por exemplo, do Fundo Global, esses ainda implementam algumas atividades, mas a nível nacional nós estamos a discutir a possibilidade de incluir as campanhas de tratamento massivo a que me referi acima, por exemplo, com a campanha de distribuição de redes mosquiteiros. Isso é um assunto que está-se a discutir a nível interno com o programa de malária. Mas também temos outros programas como de nutrição, assim como de saúde escolar, que têm realizado intervenções massivas de distribuição de medicamento. Também estamos a interagir com esses 2 programas para poder integrar as campanhas de tratamento massivo de xisto e elementíase transmitidos pelo solo. Aqui só precisaríamos de ajustar o grupo-alvo, porque cada programa tem um grupo-alvo específico. Então, estamos a discutir a possibilidade de incluir essas intervenções. Ah, também estamos a discutir ainda com saúde materno-infantil para ver o que é que pode ser aproveitado do ponto de vista de intervenções que eles têm desenvolvido para garantir que o medicamento que o país tem não expire o prazo. Em relação aos inquéritos, como disse, temos uma série de inquéritos, porque temos muitos distritos que vão realizando algum trabalho, mas quanto aos inquéritos, ainda é um desafio, mas ainda estamos a tentar desenhar algumas linhas de integração, tendo em conta a outras pesquisas que podem ser feitas, por exemplo, com o programa de malária no âmbito de gestão integrada de vetores. Podemos ver se é possível integrar esses inquéritos, por exemplo, de FL para com o programa de malária. Bom, por enquanto é esta estratégia de mitigação que está sendo desenhado a nível do país. Mas salientar que próxima semana nós vamos receber a comunidade Kikundi, que é a comunidade de gestores de DTNs a nível de África, que tem uma clara vantagem em relação à estratégia de, de advocacia para financiamento doméstico. E esperamos que com essa visita possamos ter ferramentas ideais para discutir a nível do governo para que olhem para as DTNs como uma prioridade, de modo a garantir que haja um financiamento específico para a área de doenças tropicais negligenciadas em Moçambique. E obrigado.
Muito obrigada, Dr. Hennis. The most part of his presentation was really reading the slides, so I didn't type. The only thing that was a bit different is that next week they are receiving a visit from Kikundi, that is this community of practice for NTD program managers in Africa, and they are going to use that opportunity for doing high-level advocacy at country level to try domestic resource mobilization for some of these campaigns. The rest of the things were reflected in the slides that were translated into English. Thank you so much, Dr. Hennis. We have one more. We have, I don't know if Dr. Abdullah is actually connected.
Yeah, I'm connected.
You're there. Excellent. Please go ahead.
Yeah. Good afternoon, everyone. I'm presenting on behalf of the Sierra Leone NTD team, Ministry of Health and Sanitation. Yeah, the most urgent activity we have in our program for this year, although we have more than this, but these are the most urgent ones that need attention towards control and elimination of NTD. We are planning to conduct mass drug administration for Schisto and STH in 9 endemic districts and targeting about 5 million population. And then also we also have impact assessment for onchocerciasis in 6 districts as planned. And also we're looking at TAS 2 and 3 in 6 districts. And then we are looking at Schisto STH reassessment survey in area where we have not been conducting mass drug administration for schistosomiasis. We want to have a first-hand information on those districts, because since they were not endemic with schistosomiasis, we are planning to integrate the schisto assessment with the STH in the 7 districts that we are planning in February this year. Although it's almost getting late, and also mass drug administration for onco and STH. For your information, we already stopped mass drug administration for LF because we've just done the last pre-test in 1 IU. We are in their past and join the others in the surveillance stage. Next slide, please. Yeah, these are the drugs we have at hand now. The ivermectin expiring date in August 2026, and then albendazole in 2027, and then praziquantel in September 2025. So the most one that is edgy with others is the praziquantel, although most of them have longer expiring dates for the albendazole and ivermectin, but the praziquantel is really the challenge for us now. Next slide, please. And then this is the mitigation strategy that we are using in place for sustainability commitment. We are trying to engage the Ministry of Health and WHO to see how they can step in to mitigate this challenge that we are having to conduct this mass drug administration for both onco, LF, STH, and SCH in all the targeted districts. We also identify possible ways of mainstreaming the PCNTD MDs into existing structures like the school health activity. We have a school health program in the Ministry of Health that is conducting outreach activities in schools, school sanitation, school hygiene, and other health education packages. So we can also leverage that platform to reach out to the school in the Schisto MDA. During their activity, you can use that platform to give the praziquantel to school-age children. And also, we have some intervention in the Ministry of Health, the expanded program in immunization. We are also using that platform. We are in the nurses do outreach activities during that period. If there is no way of getting funding, since USAID funding has been freezing, we can also use the EPI outreach activity using the health staff that are going into this community to do API activity, to take the drugs announced to give to the CDDs and then motivate them to do the mass drug administration. And also reproductive health, they have CHW in the country, although not enough for the MDA for onchocerciasis. But we can also use that platform, the CHW, community health workers, who will give drugs for not only for reproductive health, but also for malaria. You can also use that platform and give them the drug to reach out to community, moving from one community to community as they used to do for the reproductive health program. That's also another strategy we can use. For the long-term plan, the NTD program, we need to advocate for the NTD program to be included into the national health policy and planning, so that whenever there is support, the NTD can also gain from that support as a program to reduce the donor dependency, like what has just happened with the USAID funding. But if there was funding from the Ministry of Health for NTDs, I think that can also serve as a mitigating strategy to reduce the threat that is always facing the NTD program over the years. Next slide, please. Thank you very much. I think that's what we have as a program.
Thank you. Thank you so much, Sierra Leone. We are going to pass now to Tanzania.
Hello, everyone. I am Clara Jones, the program manager for the NTD in Tanzania. Actually, USAID has been the primary partner supporting the government of Tanzania in its NTD control program since 2009. And in the FY 2025, USAID has committed to support a number of activities. So the one I'm going to present here are those which we feel that our key priority activities affected. But being the main funder, that means it was supposed to support across all the 5 PCT. So looking at them in terms of MDA, actually, for onchocerciasis, we had planned to conduct MDA in 24 districts, where we have 15 districts receiving twice MDA, and the rest is receiving once. So we were supposed to do the MDA in February as well as August. And so for now, we are really struggling to ensure that we do the February as well as the August MDA. And for LF, we had planned to conduct MDA in 4 districts, where these 2 districts were to do the regular MDA, and the 2 districts was to do the targeted MDAs, following the results from the assessment surveys. And we are also supposed to do the MDA in 3 districts in Trachoma. And for Trachoma, actually, these were the last MDAs in May, before we do the TIS, the trachoma impact surveys. So these districts also are affected by this stopping of MDA. And we are supposed to do the MDA in schistosomiasis in 35 districts, as well as for soil transmitted helminths in 41 councils. And you can see the total population who are affected, who were to receive the PCT across all the 5 PCT NTDs. And also, we had planned to do the disease-specific assessment, where we were supposed to be doing mapping and impact assessment across different diseases. And for onchocerciasis, again, we had planned to conduct MNE, monitoring and evaluation surveys, in 9 districts. And we had planned to conduct onco-elimination mapping in 3 districts, and the coverage evaluation survey in 4 districts. With the coverage evaluation survey, we had already collected the data, awaiting analysis and report writing. And for LF, we had planned to conduct EMS in 3 IUs, TAS 1 in 3 EUs, evaluation units, and TAS 2 in 7 evaluation units, as well as TAS 3 in 4 EUs. So for the purpose of LF, actually, we have been really affected because we won't be able to make the decision, because we are at the point of doing these impact surveys as well as the surveillance to ensure that we reach the elimination targets. And for trachoma, we had 5 evaluation units, which were due for TIS, and we had planned to conduct in June as well as December. Next, please. And other activities which are affected by this freezing is we had planned some strategic or technical meetings, whereas for onchocerciasis, we are planning to have the NOEC in March, and we had planned to start developing the dossier, as well as we had planned to do the cross-border meeting with Mozambique. And for LF, again, we had planned to do the dossier updating. We usually do this annually. And for trachoma, we had planned also to do the dossier updating. And for SHIST and STH, we were supposed to conduct an expert advisory committee meeting to inform the program on what decision to make with regard to where we are right now. And on the component of procurement of health commodities, actually, USAID has been supporting us through RTI to procure the Ovistin, RDT, ELISA, and FTS to do all these surveys. And also on the component of drug management, we had planned to conduct the meetings to prepare the JAP as well as the TEMPU for requesting of drugs from WHO. And also we had planned, during the activities, we usually do the transportation and distribution of the disease of the drugs. So actually this is also going to be affected. Next, please. So the medicine at risk of expiring, we have categorized this medicine into 3 categories, where we have the high risk. That means those medicine in country which, if at all want to be doing MDAs, they will expire between February and April. And we have the quantities with low risk, those expiring between May and July. And we have those with which are very much not at risk, and those are expiring from August onward. So if you look at the albendazole, we have around 2,000 albendazole which are expiring between February and April, and the rest are not at a very high risk. And for ivermectin, the risk of expire is minimal, because most of the drug, actually all the consignment we have in a country expires after August. And for Praziquantel, we have 7,920 drugs expiring between February and April. And actually we had planned to conduct MDA this February, and some of the activities have been started before the freezing of the activities. Next, please. So the national solution opportunities, first of all, they are in the country right now in Tanzania. We are in the process of preparing the budget for the next financial year, which starts in July. So now we are really advocating and working really close with the district authorities to ensure that they include the core programmatic activities in the CCHP, the Council Comprehensive Health Plans, to ensure that all the activities which will be done from July are accommodated in the budget at the LGAs. And so this will cater for the MDAs which were planned to be done in August. And also we are looking at integration of PCMDAs into distribution campaigns like vitamin A, as well as vaccination campaign. And for vitamin A, again, we are looking at the MDAs, because we usually do MDAs in August. So for those MDAs which were to be done in August, we are looking at working with the vitamin A, working through the vitamin A campaign to ensure that they are also distributed, as the modality for distribution of vitamin A is more or less similar to what we do in the MDA. And also we are looking at modifying the MDA distribution mechanism, where instead of using these community drug distributors, we are looking at engaging healthcare providers, extension officers, community leaders, as well as CHW in there to distribute the drugs. Because actually, if we use the employed staff to do this work, it will be easier rather than using the volunteers or the CDDs who usually pay after doing the activity. And also we are looking at extending the distribution period, because in the past we usually do like the campaign within 7 days. Now we're looking at extending, because we'll be having few people doing the distribution. Then we can extend the distribution period of up to 30 days to ensure that everyone is reached. And we are also going to include some point distribution at health facilities as well as village officers. So apart from house-to-house MDAs for community MDAs, we are also looking to be doing the point distribution. For school MDA, actually, the country has managed to use the domestic financing. So we are not very much worried with the school MDA because we know that we started that this year. We were able to do the MDAs using the local sources and it went well. But now the issue is with the community MDAs where we are looking at how we do it. Why usually we have been using the CDDs to do the MDs. And another area is partner engagement. We are also looking into engaging more partners who can support partly, because for us in Tanzania, with regard to distribution, it has already been integrated in the ELMS. So actually at health facilities, they can request the drugs from the central level up to the health facilities. So now the component which we really feel that we need to work really hard to ensure that we do the MDAs is how to get out of the health facilities to go to the community. And so having said that, for the February MDAs, which were for OV as well as LF, we are looking at modifying the strategy to ensure that the MDAs are done in February, because we feel that if we want to be able to do this MDA at the right moment, this will delay the attaining of the elimination goals. And actually, for the impact assessment surveys, we are not really working on them right now. We are more concerned with the MDAs to ensure that everyone gets the drugs as they require. Thank you.
Thank you. That was truly, truly excellent. And definitely we don't want any further delays. So it's excellent that you guys are trying to find those national solutions. We go to the next country. I think we have Nigeria now. No, Uganda. Do we have Dr. Alfred in the room? Dr. Alfred, you didn't. Unfortunately, Dr. Alfred is not present. So while we sent him a text message, maybe we are going to pass to Nigeria, where Dr. Clara has kindly agreed to present for Dr. Makata, because Dr. Makata is actually on his way to Mozambique on a mission. So she's going to present for Nigeria as well, but do not get confused. She's not from Nigeria. Go ahead, Clara.
Thank you. So on behalf of Dr. Chukwuemeka Makata, I'm going to share what is happening right now in Nigeria. Good thing with Nigeria, they have done a lot of this work for a certain period and they have stopped MD in some of the areas. So actually very few areas are affected in terms of MD, but they needed the support to do the impact assessment. So for the activities which have been affected in Nigeria, this include the Onchocercase elimination program in Cross River State, where they were supposed to be doing mass drug administration as well as assessment, and around 3 million people are affected by this freezing. And also they had planned to conduct MDA in Enugu, Ebonyi, and Edo states, as well as post-transmission Hello, can you hear me? Hello?
Yes, we can hear you now. I think we lost you for a minute.
Hello? Okay, yeah, so, and also for OV, mostly it's some few areas where they're supposed to be doing mass drug administration. And for lymphatic filariasis, it was task 3 in Cross River, where around 3 million people are affected by this freezing. Next, please. So for the medicine at risk, there is no much to expire in the country since most of the states have stopped treatment, as I mentioned earlier, and are conducting post-treatment surveillance with minor treatment at hotspots. So the drugs they have are not at a very high risk of expiring. And the national solution, actually, they are having the discussion with Ministry of Health to see if there could be some support under the Minister's Collaborative Action Strategy. And also, Nigeria is part of the Health Campaign Effectiveness Program, who has developed Ministers' Collaborative Action Strategy that seeks to integrate the delivery of multiple health programs jointly to achieve efficient use of resources like vaccine, malaria, as well as NTD. And also, they are exploring the integration of these activities in the Reaching the Last Mile Fund.
Many thanks, Clara. And I believe that when Dr. Emeka is saying that there is no medicines close to expiration and that they are, I think he probably is only referring to onco. I don't think he's covering in this presentation Schisto STH as we had requested. So let's not take this, since he's not here to clarify, I wouldn't, probably they have medicines like praziquantel and others, but let's just, we don't know, he's not in the room. I'm just saying, I'm not entirely sure that he's covering also Schisto and STH in his presentation. Excellent. So I think with that, we only had the remaining presentation of Uganda, and I don't see the program manager present. So we go back to his slides 1 second. And while we go to these slides, no, we just passed them. Uganda, next one. This is the one, yes. Perfect. So while we cover his slides quickly, maybe I'm going to invite all the attendees, if you have any comment or anything you would like us to discuss after this presentation, please type it in the chat while I am speaking. If there is any question, any comment to be made, please type to everyone in the chat. And for Uganda, we are looking at 5 districts being affected. And for OncoMD8, also 2 refugee settlements. Due to the cross-border transmission, Uganda has planned to conduct NDA at the same time of the Republic of South Sudan. So it's a shame if it's not done at the same time, because the migratory populations will keep harboring the parasites. So it's important to maintain those activities. And they had many planned activities supported by USAID, including drug donated by donor like Mectisan donation program may stop since they need assurance of the availability of funds before the shipment of the medicines can be sent to the countries, obviously, and also insufficient supervision. Next one, please. They have ivermectin expiring in February 2026. That is in less than a year for now. So definitely important to distribute in 2025. And the national solutions that they are proposing is to integrate NDAs into the child health days, to advocate to partners for alternative sources, to integrate the onco treatments into the health regular mainstream programs, to include the senior top management they have written a circular directing all hospital directors and all stakeholders to integrate all health programs that have been supported by USAID, including HIV, tuberculosis, into their mainstream. So this is an excellent opportunity, and it's great to see the leadership already taking action. All hospital directors and district public health services committees to recruit more staff to fill gaps left behind by the USAID supported staff. So another excellent fast action that they have taken. The Ministry of Health is pushing Parliament to release supplementary budgets so that services are not interrupted. And I believe this is the last slide from Uganda. Very good. So I am gonna now go to the chat and see which comments we have there, and then we are gonna dedicate the last few minutes to wrap up and identify specific next steps. So if you wish to put down the presentation, Nadia, for a second while I read these ones. Okay, we have a comment from Dr. Daniel Dagne from WHO asking what's Ghana's plans to mitigate the impact of the USAID stop, if they can highlight that a bit. So I'm gonna pass the floor to Ghana. I think it's what they presented probably already. Do we have Ghana? Maybe Ghana is not present, Daniel. Is Ghana present?
Joseph is there.
Dr. Joseph Opare, maybe he has lost his connection.
Okay, while
Hey,
he
I'm
come
here.
back, Joseph,
I'm
I
here.
think
Yeah.
you already presented on what are you trying to do for mitigating, and Dr. Daniel is trying to ask you if you can elaborate a bit more on what specific steps are you taking, what action specifically are you taking right now to put in place your mitigation plan. So if you can just elaborate a little bit for Daniel.
Right. So from what I said, we got this news about, I think about 3 weeks ago. So there's a lot of confusion as to what we should do. Okay, but immediately we know that for malaria, they are going to do seasonal malaria prophylaxis. Okay, so it's a golden opportunity for us to go and negotiate with malaria and do it together if possible, because they are going to touch base on the individual households, okay, in the country. So why can't we also join them to do that? Then we are looking at, let's say, the OPDs and the CWCs to see if there's any possibility of giving some of our medication over there. All right. Then the other thing is with the schools. Already the Shisto School Development Activities is done in collaboration with Ghana Education Service. But when it comes to the training, we do, Ghana Health Service does the training, okay, and we get a support from USAID and so forth, right? So we are looking at how this time, either we use Ghana Health Service staff mainly, but we leverage on the schools so that we shall go and do the distribution at the school level with the teachers also supervising, or because it's in their premise that the distribution will be done. So instead of we going to look for money to train them, okay, we shall go there and use leverage on their premise and instead give the medicines over there instead of involving the Ghana Education Service, which wouldn't be a very good thing to do. So these are some of the areas that we have in mind. Yeah, thank you.
Thank you so much. I'm gonna read a comment that said that the private sector engagement is particularly important with concession companies operating in rural areas. Maybe they could be potential sources for resource mobilization for entities and health system in general under their corporate social responsibility. That's a great idea to try to mobilize also these corporations working in countries. Also, there's a couple of comments saying that we have a little challenge in some places where some of other campaigns are also funded by USAID, and how the countries will have to make an effort to identify regular health system services that are not funded through USAID, that obviously countries are not 100% funded by USAID, luckily. So we will have to find those services that are actually regular, that are coming through the Ministry of Health, and that are not affected by the freeze, so that we can obviously identify the integration. We cannot target those that are also affected. That is a great point. Let's try to identify the right ones. Let's see if I can see any other comment.
There is one which needed clarification from
Yes,
President.
clarification, I think that's for you, Clara. If you can clarify, you explained it that instead of doing one day through the community volunteers, you were going to do it through the health facility using the personnel working in health facilities and across more days. So obviously, because they have also irregular jobs. So if you can clarify how are you doing that, because it's very unique and excellent idea. Go for it.
Okay, so thank you very much, Maria. Actually, what we plan to do, usually we do it through like MDA takes 5 to 7 days, and we use CDDs where we have these community drug distributors, a lot of them, and they are given a target of certain houses where they are supposed to reach. But now with limited resources, because we know we may not be able to like compensate these CDDs, we are planning to use the community health workers. And in the country, actually, there's establishment of these community health workers where we have like 1 or 2 community health workers per village. So for them to ensure that they've done it, then they will need more days. So we plan to use the community health workers, but also we plan to use the health facility workers. So at point where the community health workers cannot go, then the extension officers or the staff from the health facilities, nearby health facilities, will be doing this, and it won't happen definitely in 7 days. They might need more time because they also have other activities to do. That's what we meant. I think it's clear now.
Thank you. And I have a question from Irene from Alma to all the panelists. to see, okay, now you said you are going to advocate to political leaders to increase domestic resource mobilization, but how that practically happens? What steps are you going to take to do that level of advocacy? And I'm going to expand that question to say, and also the other things, like how are we going to engage the Ministry of Education to be able to deliver through the schools and all that? So can we now go to the steps? What are we going to do specifically to advocate to the government? Is going to be a meeting? Is going to be what? What are we planning to do to achieve that high level advocacy? And I let any of the countries to take the floor and share ideas. Clara.
So actually for us, we were like that during the USAID era, we have been doing a lot of health system strengthening activities. So actually what we did, this now goes to those who have not started yet, because for us, we've been doing it for the past 2-3 years now. What we did is we actually ensured that we identified what are the key areas where we think could be the source of funding for NTDs. And one area we identified was actually the local government authority budgets, because that's where the activity is done. So in that area, we had talked to worked with the budget officers from the district, and we had also involved the people from the education department. So we had agreed that the portion, if we are going to be doing school MDAs, that means the people from the department, education department will have to set some funds to support that component where they'll be paying the teachers who are doing the MDAs. And if we're doing community MDAs, then the people from the health department at the local government authority will have to set some funding. And actually this has been really rolled up. And so the only way to do it, from my experience in Tanzania, is just to identify what are the key areas where you feel as a country that they are more likely to get funding to do the MDA. And this has to go down to the local government authorities rather than thinking of like setting the budget at the central government. Because if you set at the central government, it's gonna be you need a lot of money to cover all your councils. But if they do at the local government, each local government will set specifically according to their priority diseases and according to what they have in that council. And also one area is also to ensure that we integrate the medicine into the supply chain so that it doesn't add to the cost of distribution of this medicine. Thank you.
Well, that's a really great thought to see how we can decentralize and look at the regional governments, because it is true, sometimes doing things from the central level is much more expensive, and instead trying to identify local opportunities in the regions, in the districts, could actually be much more functional and more effective. So that is great. Let me read a comment from Isaac in the chat. It is good to see all these great efforts by countries for domestic resource mobilization. I will encourage to actually look beyond just the emergency stopgap cover that needs to happen obviously for this year, but also look towards a longer sustainability plan for entities, because all this freeze affects programs across the health system and that were supported by USAID, and we have the risk for entities being further neglected and not being prioritized in the Ministry of Health. So we need to make sure that we do this mitigation plan, but we also do long-term sustainability plans. That's really a great point. So maybe we can actually dedicate these last 5 minutes to try to see what are the next steps. I think we put one slide together with some of the thoughts. Maybe we can present again the last slide with some summary thoughts. I think we heard that, maybe put it in presentation, thank you. We could immediately organize an urgent meeting, or almost an emergency meeting at national level with different ministries, such as the Ministry of Health, Ministry of Education, Ministry of Finance, and try to have a conversation and also involve key local partners. We discussed it about NGOs, but great idea of also invite the corporations, like people that could have local funds. This can be at the Ministry of Health, but that can also be at regional level. Maybe this is something we learn in this webinar, no? Try to involve the regional level, not only the central level. Try to identify opportunities to integrate the transport of NTD drugs and products into the regular supply chain of health to the health facilities. And then we were talking about what happens from the health facility to the communities, or maybe the distribution is going to happen through the health facility. No, this trying to look at these opportunities. Integrate health campaigns with people-centered approach with any other campaign that is not being affected by the USAID freeze. No, try to seek what other partners are supporting what things are being more supported by the regular funding in the government and not affected by the freeze, like vitamin distribution, campaign distribution, anti-malaria. Is there anything that was not affected? Integrate EPI surveillance and impact assessments into existing epidemiological surveys, such as malaria surveys and others. But clearly, it's very clear from the presentation today that each country is going to have to tailor their plans to their specific situation and the opportunities they have. And therefore, we are inviting all of you for this webinar today to just be the first day of a long-term conversation that we have to have as a community. So I am inviting all the panelists today to develop these national action plans, even if it's in draft, even if it's something very imperfect, and share them back with GON and with WHO by March 30th, in a month, to ensure we continue supporting each other and we have coordination, transparency, so that the medicine donation programs can also have access to that information, so other partners can see how to leverage in the opportunities you are presenting. So I think this could be some clear next steps, and I am going to open the floor to any of the panelists to see if there is any other next step that we could integrate in these key takeaway messages. If you can see any other step that is missing there. Or anyone from the chat as well. And if not, while you think that, I can see if Joseph, please go ahead.
Yeah, I also think that we could also leverage on the support from other partners who are not getting their funding from USAID, like World Site Savers. We wrote to Site Savers listing all the gaps that we have at the moment if we are supposed to continue the US freeze. And they asked us to submit in detail all that we are going to need. So we hope that we shall get a positive response from somewhere. So all that I'm saying is that we could also leverage on the other health partners we are working with. Probably they have support to continue to with us. Thank you.
Thank you so much. And when we receive support from other partners, we have to be creative and say, okay, how this dollar can now serve twice what it was planned to do before, how we can do things in a more efficient way so that with the small support we have, the government can step in with national opportunities and actually multiply the impact of that support we are receiving from other partners such as Site Savers, MFAN, and others. So that the amazing, beautiful medicines that we receive that are really the core of this program do not get wasted. And also that we don't have that bump back into the transmission that will set us back years. So it will be really, really bad. And I think, yes, trying to leverage in those opportunities would be fundamental. With this, we are on time. I see one last comment from Isaac. Maybe the national plans should go to all entities. Yes, absolutely. That's a great point. Thank you so much for saying that, Isaac. We have a communications platform being developed across different partners, WHO, different donors, and we are sharing all the information. And also for your information, the GON network has a really long list of distribution. So it is shared definitely beyond GON for all entities. And that's why when I said sharing with WHO ESPEN, because ESPEN is the Afro-regional office for Africa, and we will make sure that absolutely everyone receives this information because we need to be together. We need to be stronger together and well coordinated. So be assured that anything you share with GON, anything you share with WHO will have a wide distribution to support you and to help you as much as we can. But let's finish this webinar in a positive note, saying how much it can be done with national solutions and how much is possible to do when we mobilize communities, when we mobilize countries, when we really utilize our domestic opportunities and our creativity to find solutions in the middle of the different crises. It's not the first time we go through a crisis together, and we know it is possible. So let's continue working together and doing as much as we can to make sure that the people we serve are not abandoned and neglected. And with that, I thank you so much for your participation today, and be sure that we will continue the conversation. Thank you so much, everyone.
Bye.